My name is Naomi Inglar. I'm the Communications and Training Coordinator for the Tulane Prevention Research Center and the Tulane Center of Excellence in Maternal and Child Health, two of the organizations who are sponsoring today's seminar and the series. I also want to thank the student groups who are co-sponsoring with us this series. It's the Spring 2018 Health, Racism, and Communication Seminar Series. The student groups are the Society for Young Black Public Health Professionals, the Tulane African Student Association, Salud for Latin American Communities, and the Tulane Society for Sexuality, Health, and Gender. Without these student groups, we wouldn't be able to be putting this on, so I want to thank them very much. Some reminders, please do sign in outside and take an evaluation form. Filling that out is really important because it helps us plan our next semester's seminars and lets us know, are we offering you the trainings and information that you want and need for your work. Also, we are using a hashtag for our seminars, so please feel free to tweet and put on Instagram or Facebook. We're Facebook Living this on the Center of Excellence in Maternal and Child Health Facebook page. And so the hashtag is hashtag Tulane HRC Seminar. Also want to give a reminder that our third and final seminar in the series is a week from today, same room, same time. And we have Dr. Tammy Lewis-Wilborn. Her seminar is Minding Your Bias, Using Mindfulness to Promote Culturally Responsive Research. And we have Simone here from the Society. We'll be introducing our speaker.
Hello everyone, my name is Simone Brown. I'm the president for the Society of Young Black Public Health Professionals. Today I have the privilege of introducing Dr. Joia Crear Perry. Dr. Crear Perry is the founder and president of the National Birth Equity Cooperative. Most recently, she addressed the United Nations Office of the High Commissioner for Human Rights to urge a human rights framework to improve maternal mortality. Previously, she served as the executive director of the Birthing Project, director of Women's and Children's Services at Jefferson Community Health Care Center, and as a director of clinical services for the City of New Orleans Health Department, where she was responsible for 4 facilities that provided health care for the homeless, pediatric, WIC, and gynecologic services within the New Orleans clinical service area. Dr. Crear Perry continues to work to improve access and availability of affordable health care to New Orleans citizens post the Hurricane Katrina disaster of 2005. After receiving her bachelor's trainings at Princeton University and Xavier University, Dr. Crear Perry completed her medical degree at Louisiana State University and her residency in obstetrics and gynecology at Tulane University School of Medicine. She was also recognized as a fellow of the American College of Obstetrics and Gynecology. A proud recipient of the Congressional Black Caucus Healthcare Heroes Award, Dr. Joia Crear currently serves on the Board of Trustees for Community Catalyst, National Medical Association, and the New Orleans African American Museum. She is married to Dr. Andre Perry and has 3 children, Jade, 24, Carlos, 21, and Robeson, 7. Her love is her family, health equity is her passion, maternal and child health are her callings. Everybody, please welcome.
All right. Let's see. So they said if I stand near the microphone, you can hear me. Is this working? No?
You don't have to be that close.
Okay. I don't know.
You can move around.
I can move around. Okay. Well, good morning still, yes?
Yes.
Yes. All right. Good morning. I'm excited to be home. Hey! Oh, we got the whole posse! I'm at home, yo. This is great. I have been flying around everywhere. I literally got on a plane at 12:35 a.m. in San Francisco after doing a screening there of the documentary we're in. Landed here, took a shower, and walked in the humidity from the Roosevelt to see you guys. I was like, oh, I am home. It is hot. So thank you so much for having me. Thank you to Shokafe, where is she? Yay! We've been in this fight for some years together, so I appreciate having the opportunity to come and speak here with you all. Thank you to Carmen, without whom these slides would not exist. The magical Carmen makes me look smart all the time. And she actually started with me as a student right here with you guys. So she would come and do her student internship, and now we get to do all kinds of stuff all over the world together. So it's pretty amazing. Because you guys are the future. So I am happy to be here. And really, if you listen to nothing else I say for the next hour, what I need you all to be is actively anti-racist, right? This is the goal of this day, is to understand what that means and why it's important for all of you as future leaders of state health departments, as future leaders of the CDC, as future leaders of Tulane School of Public Health, I need you to understand that you have to be actively anti-racist. Okay. So these are our objectives. I give these talks at like Grand Rounds and other places, and normally after you give objectives as a physician, you give disclaimers around who's paid you. Nobody pays money for equity. So I have no disclaimers, no financial disclosures, no pharmaceutical companies interested in this, shockingly. I know y'all are surprised by that. So when we started the National Birth Equity Collaborative, which it's been 3 years old, yay! We didn't have a definition for birth equity. So we created one for our own organization. We sat together as a group of our staff and went through and we looked at, I think some students helped with this as well, some definitions for equity in general, some definitions for health equity in general, thinking about what our goal and our mission for our work was. And this is a combination. You know, a lot of the definitions speak of equity as a place. Like when we reach equality in all these metrics, we will have then equity. But we recognize with our current political situation that sometimes you get a couple of steps ahead and then a step back. And so maybe it's not so much that we're looking for this magical place where things are equal, because there will always be people fighting against equality. There are always people who use divisions in order to create wealth for themselves, to create power for themselves. So instead of looking for it to be a place, looking for the assurances that it always holds equality as the value system that we need, right? So what are the things and the systems inside of public health to place the assurances for equality? So that's why our definition is the assurances of the conditions of optimal birth. So not that we just get to live, but we get to thrive for all peoples with a willingness to address racial and social inequality. So we can't act as if we don't see race anymore, we're colorblind, and so we'll just move forward. We have to address the things we've done and a sustained effort. I do not expect that my grandchildren will be here on this earth and everything will be kumbaya and we fixed everything and we don't have to think about equality. We're gonna always have to use that as our value system set, okay? So then that makes it easier to not think that you're gonna have a 3-year grant that's gonna fix everything, right? It's not gonna happen. So our original mission was really about infant mortality. And just like everybody else, we were not thinking about moms. No one cares about moms, and especially women in this country, and then black women. By the time you get to that, we're just totally forgotten. And so when we really, about a year into our organization, we changed our mission to include maternal. So our mission is to reduce black maternal and infant mortality, I should go back here, through research, family-centered collaboration, and advocacy. And we then had to change our vision. And our vision is that every black infant will celebrate a healthy first birthday with their families. And then whatever that construct of family is, right? Family could mean grandma, family could mean 2 dads, family could mean whatever, but we want people to be, babies to be able to live for at least a year and be healthy within their family structures, however that looks for them. So one of the organizations that I have the honor to be a part of is the Black Mamas Matter Alliance. I'm on the steering committee of that. I actually chair the CARE committee, and we are a black woman-led multi-sectoral alliance, and we center black mamas to advocate, drive research, build power, shift culture for black maternal health, rights, and justice. And each of those words are really important, especially thinking about research. Who is putting the research agenda together that centers black women? Where does that come from, that we understand that being black is not the problem, that centering us and knowing that we are an asset? How do you then center research that says that we're an asset and not the problem, among other things? So we want to go through some definitions. I feel like I missed this. So we want to go through some definitions. And so one of the definitions of, who's heard of the term reproductive justice? Yeah, all right. So I don't have to define it for y'all. Y'all all got it down. You know, being on the Black Mamas Matter Alliance steering committee, I get to be in meetings with all these amazing reproductive justice folks like Loretta Ross and some of the other women who kind of created the term, and think about the political climate at the time that they came up with this. This was the first iteration of healthcare reform. This was the beginning of the Clintons trying to start with, healthcare reform. And for reproduction and for women's reproductive, there's a lot of conversation around abortion, a lot of conversation around abortion access. And black women really felt left out. For us, abortion is important, but it's not the most important thing. Because if you're worried about your child being seen as an adult at 14 and getting shot in the park, that's way more important for your reproductive health than if you have access to an abortion. And so really centering all the other things that goes on with women of color when it comes to our reproduction, and honoring the history of reproductive oppression was really important with the tenets of reproductive justice. So for us, it's not just rights or health. I don't just need a clinic, and I don't just need a law that says I can get to the clinic. I need you to treat me justly. So I need personal bodily autonomy. So you don't just get to tell me I have to have my tubes tied, or because I'm poor, I'm supposed to have a lark because you think I have too many children. Those are your judgments, not mine. So it's important that we have personal body autonomy, that we can have children if we like, and as many as we like, or not have children. If women don't want to have children, they don't have to. We're not just here to be wombs, to bring on folks to come and be laborers. And that our children are safe. This is a big, crucial one, and can live in the communities where they are safe and sustainable communities. And that's really this working inside of this anti-racist framework. And in order to do that, we must analyze power system, address intersecting oppressions like criminal justice, like education, like mass incarceration, center the most marginalized, and they have to join together across issues. So this just can't be a public health issue, or just can't be a healthcare issue. It has to be all the sectors coming together. So we have 4 programs currently, along with a whole bunch of consulting things that we do, recognizing that we'll walk through a little bit of the Campaign for the Black Babies, which is what we were funded for originally from the Kellogg Foundation to do, and it's kind of our seminal piece of work. Safe Landing, Birth Equity Solutions is our consulting, and then the Black Mamas Matter we talked about a little bit. So for the Campaign for Black Babies, Carmen and some others interviewed Black women across the country who'd had a infant death, sorry. Hard to interview maternal death. And so we picked these cities. These are the cities that have the highest numbers of Black infant death, not the highest rates. If you put rates, you get different places. You'll get Chattanooga, Fresno. These are actually just numbers, because the goal for a campaign is to get people motivated. So if I say 3,000 Black babies could live who currently die, that gets actual people motivated. When I tell you public health, the epi people are always 12 per 1,000. That gets y'all excited, I guess. I don't know. But for regular people, we need like regular numbers, right? I'm a simple OBGYN. So if we do this work correctly and we meet our goal, then that's 3,000 babies that would live that don't currently live. And what we heard in interviewing the women was the importance of this mixture of both clinical and social, right? Because yes, it's nice to have a provider who you have access to and you can come to, not just when you're pregnant, but your entire life course, and you have opportunities, but this mixture of what happens when you leave the healthcare system. And some organizations, do we have any Healthy Start folks in here? No? Yeah, so one of my first entrees into public health was being the medical director for the local Healthy Start here. And it's great as an OBGYN, it's like, wow, so there's an organization that their job is to case manage pregnant women. Who knew that this exists? Even though I haven't practiced in here and done residency or medical school here, I did not even know it. So this disconnect between the clinical and the social is how we get some of these inequitable outcomes. So we need to put them together. So we have to dismantle systems of power and racism. We have to assess and educate on social determinants of health inequities. When we leave off the inequities part, people start not understanding the point of saying social determinants of health. It's not like we got here and we have inadequate housing because it fell out of the sky. Policies made it inequitable, right? And so we have to make sure that we're talking about the inequities. And working in the areas of overlap are reasons. This is what Dr. Art, one of my great mentors, who's up in Ohio. Healthy Start, Nurse Family Partnership, and centering why they work in this infant mortality space and maternal mortality space is because it's a mixture of both clinical and social. So let's talk about the social determinants of health inequities, not equalities. So it was a big move. Right after Hurricane Katrina, the World Health Organization came to New Orleans, and everybody came here. And I remember sitting in big rooms with all these fancy muckety-mucks talking about moving the language from individual responsibility to this amazing new idea about social determinants and how we could put together structures to talk about the importance of things like having safe and affordable housing and how that impacts your health, having a living wage and how that impacts your health, quality education, transportation, availability of food. We know, especially in New Orleans right after Katrina, still now, there are parts of the city that don't have access to quality food that's reasonably priced. Social connection and safety, and also job security. So this is a big step for us to even talk about that layer of social determinants of health inequities. And we know that because they're inequitably distributed, you get psychosocial stress and unhealthy behavior. So people don't just decide to eat Cheetos because Cheetos are there. They are stressed, right? So obesity is not just something that magically comes out of the air. You have all these other things that happen that cause unhealthy behaviors. And this leads to a disparity in the distribution of disease, illness, and well-being. And this slide really, which was adapted by the Michigan Public Health Institute, is really important because it helps you to see that this middle level of social determinants is so important, but above that, we have a power and wealth imbalance. So it's really critical that although we want all of you public health folks to go out and work on these social determinants, if you don't understand that there's a power and wealth imbalance, you're going to get very frustrated trying to get a living wage passed, and you can't get it passed. Why wouldn't people want a living wage? Makes sense, doesn't it? Well, that power and wealth imbalance is real. And it's around labor markets, which is living wage, housing policy, gentrification, not having access to affordable housing, education systems. Why do we underfund the public school system? Why are the public school system more segregated now than they were when we desegregated them? Globalization and deregulation. Why are we having plants and more pollution? Our social safety net. Why do we say things like we don't need CHIP? Because those people use that money to go shopping. Having social networks. Why do we disrupt communities and families and say immigrants can't come into the country with their family members? That's chain migration. These are all language around power and wealth. And our tax policies. Why do we give a tax break to the most wealthy and leave the most marginalized left out? And the reason we have this power and wealth balance in the United States is because we have the root causes of racism, classism, and gender oppression. Now, if you were in other countries and contexts, you can add some more isms, and you probably can do some here, like fundamentalism, right? We're getting some religious fundamentalism, and you can see that impacting people's health. I would imagine for Muslim populations, we'll see some outcomes when it comes to birth that are going to be horrible in the coming years because they're being oppressed based upon fundamentalism. And it's our Christian fundamentalism, which we don't like to talk about. All right, so when you are working on your social determinants, just realize, yay, it's great, but you're just in the middle. You're not dealing with this power and wealth imbalance and the real root causes. And you have to at least have a framework for understanding that there are real root causes, that people are not just living in unaffordable housing because they picked it, but there were racism, classism, and gender oppression that got us there. And so how that plays out, as a clinician, when you come to see me and you've had, and I talk to you about the fact that you are at risk of having a preterm baby, what we learned from doing this campaign for Black babies and looking at the birth equity index is that this is what a doctor on the clinical side will tell you. These are the reasons why you would have a baby early, between 20 and 37 weeks. My son, who is 21, was born, and I was in medical school, and he only weighed 445 grams. I was about 5.5 months pregnant. So he's 21, he's ridiculous, and eats all my food. But back then, he was he's a micro preemie. So the risk factors are short cervix, having a previous preterm birth, having short interval between pregnancies, having a history of certain types of surgeries, having pregnancy complications such as bleeding, having a low pre-pregnancy weight, smoking, and substance abuse. But let's unpack what are some of the other non-clinical, like some of the things that doctors don't talk about. If you live if you're isolated, if you have a community that's racially, residentially segregated, we found from our data that you have a higher risk of having your baby too early. So think about all the cities. There are places where in order for the cities to be equally racially integrated, 75 to 80% of the people would have to move, right? So that segregation of populations also means segregation of funds, segregation of resources, segregation of opportunity. Unemployment. If you do not have a job, your catecholamines are rolling. You are nervous and you have a high risk of prematurity. Your median household income. We found that household income has a direct correlation with having poor infant mortality, high infant mortality. Lack of paid leave. We do not in this country have a paid leave program for folks. Other countries that have great outcomes have paid leave. Think about this baby box. Y'all all heard about the baby box, right? The United States wanted to buy boxes for everybody, but they didn't want to give paid leave, which is why other countries have better outcomes. So we picked the thing instead of actually changing our structure because of our power and wealth imbalance. Transportation access. Love the bike lanes. I know y'all love the bike lanes. It's important to be exercising and all that's hot, and humidity was real today. More people actually need reliable public transportation that gets them. If you work downtown in New Orleans, you live in New Orleans East, and your job starts at 5 a.m., how are you getting there on time? Who is worried about that person? They are not riding a bike across the high rise. And then gender inequality in earnings. We know that for across the board, women make between 60 to 70% of what men make. So just those things alone would help improve our prematurity. So getting both healthcare providers and public health and policymakers to switch their thinking around their interventions based upon understanding that these also are risk factors. So congenital malformations is how we, for the longest time, justified having genetic basis of race, genetic basis of inequalities, because we said we had higher rates of infant mortality even when it comes to congenital malformations. But the truth is, congenital malformations are not just from genetics, they're also from exposure to STIs. So if you don't have adequate sexual education, if you don't have adequate access to treatment for STIs, you're going to have higher rates of genetic malformations. If you don't have access to healthy foods, if you don't have folic acid. So all those things increase your risk of having congenital malformations. And then so you don't have substance abuse options, right? So you're seeing an uptick right now in alcohol dependence, and that causes congenital malformations. And what is the treatment option for a person in New Orleans who's pregnant who's addicted to a substance? And then SUID. So this is probably I won't say the bane of my existence, but it is my least favorite because we spend a lot of money on SIDS, a lot of money on SUIDs. It is the thing that we love to say in MCH, it's the low-hanging fruit. If only these moms would just, we can make a billboard campaign, we'll spend $500,000 to just show them. They just don't understand that they just need to put their babies alone back crib. They understand, they heard it. When you talk to moms, they're like, yeah, but guess what? I don't have heat, right? So I sleep with my baby because there's no heat in my housing complex, or there's no heat in my Section 8 housing. Y'all got a plan for that? There's the personal responsibility of language of what the women should be doing versus what we should be doing to hold systems accountable for not having rodents in their home. People hold their babies in their beds because they're afraid of the rats. I think that's a pretty noble thing to do. I'd be a little nervous about some rats and have my baby co-sleep too. Y'all have to get over it. So really not blaming moms for their social situations and then saying we can get a billboard or some flyers to fix it. I said this the other day in New York, and the room got really quiet. And then the woman who I have a contract with, who was over the maternal child health, she said, well, our SIDS program is working. I said, it works to a point, but you have really poor housing in New York City that y'all can spend some money on. So maternal mortality, same kind of risk factors, honestly. The clinical risk factors are eclampsia or seizures, cardiac disease. I know y'all probably recently saw Erica Garner passed away at age 28 from cardiomyopathy, acute renal failure, your preconception weight, having kind of conditions like diabetes or hypertension, and then having a blood transfusion, having to be on a ventilator, having a hysterectomy, or having heart failure. So those are like textbook OBGYN risk factors for having a maternal death. But the social risk factors, if you have lack of housing, you're going to be stressed. Same kind of things. Air quality. We found that you can improve infant mortality by decreasing pollution. Right? So there's a direct correlation between infant mortality rates and pollution rates. Let's just can we work on some accountability around pollution? How about some lead accountability in New Orleans? All right, yes. Okay. So going back to the Erica Garner conversation, when you looked up, so media outlets were calling me to ask for a quote around Erica Garner. So I looked up, what are the risk factors for cardiomyopathy? I had patients when I worked here and trained here who had cardiomyopathy, and they would be beautiful and young and fabulous and thin, and you never understand why their hearts were failing. But in the risk factors, when you look them up, one big on the list is black. The problem with using black as a risk factor, it presumes that the individual is the problem, and that there's something magical about melanin that then therefore causes us to have heart failure. Like, that doesn't even make any logical sense, right? White men are 28 more times more likely to commit suicide than black women. You don't see on the suicide risk factor white, right? You don't see it. So I just want us to stop doing that, right? So at some point, recognizing that racism is real, but black skin causing outcomes is not. And then Serena, with all her power and all of her abilities, still had to advocate for her own self. And she had a history of pulmonary embolus, and she still had to fight for her own, to be heard, to not die in childbirth. So these are really important moments to understand that even you can either be traumatized or you can be famous and you still not be seen as a black woman in childbirth, fully seen. So it's important that you all, my new anti-racist, or you might have already been anti-racist, have a racial equity lens. And why is that? Because race is not genetic. It's not. We completed the Human Genome Project in 2002, 2003. There is no genetic basis for race. There was so much, 400 years of trying to prove this. Recently I've been reading this book that's my new thing. Every couple of days I get mad at somebody else. It's called Stamped from the Beginning. It's by Ibram Kendi, and it's about the history of racist ideas in the United States. And so every time I read a new thing about somebody, I'm like, nah, I can't like Abraham Lincoln too. But if you think about the Tuskegee experiment, my framing, I don't know about you all, but my framing was there was some really mean people, because we usually think of racism as bad, mean people who did some bad, mean things to black folks because they could, because we're poor. That sound about a good narrative? Yeah? Turns out, they were actually trying to prove that black people had a different impact from syphilis than white folks. So the whole point of the experiment for 40 years was to prove that black folks, because we have fragile minds, we get more crazy from syphilis, and that white people got more cardiac stuff from syphilis. And so the amount of money that we still today spend on trying to prove that there's some genetic reason that things happen to black people is mind-boggling. Even if we start talking about epigenetics, if we found the epigene tomorrow, then what? We then leave people in poverty in systems that treat them as substandard? Is that the goal? So really unpacking why we need to validate this racial difference that's genetic is important. So historically, race was used as a taxonomic categorization, right? So some people decided, starting in 1500s, we're going to base it upon race. It's not that we can really stop doing it. We could, but first we have to undo the things that we did to harm by creating it in the first place. And so it was based upon common hereditary traits such as skin color, right? So that's how you can get some random places. Like when I go to Cape Town, I can be colored one day, it's all random, right? Because it's not logical. And it's to elucidate, what the goal was to elucidate a relationship between our ancestry and our genes. So it was built for that from the beginning. Or they would say God created it, right? God said we have different folks we have red folks on this continent, yellow folks on this one, and God didn't want us to mix. So we use either God or genes to make things up. So really the point is the experience of racism, not race, is what compromises health and well-being. So it's not implicit inside of people. From now on, when you think about inequities, I don't want you to think about individuals, I want you to think about systems and policies, because systems and policies created the inequities, not individual choice. And so, for example, black immigrant women, first generation, do better than second, third, fourth. By the time you're fifth generation here, but like me, it's a mess, right? You have babies that weigh 445 grams despite education and income. So it's important to understand that the protectiveness of not having been born here is real. We talked about this with our Latina sisters. So we were in California yesterday. First generation, they have great outcomes. By second generation, they start decreasing. So the impact of racism is not something innate about blackness or being Latina or any of those things. So this side really resonates for clinicians, because we love the language that the reason why black maternal mortality is so high is because there's something wrong with us. We're too old when we have babies, we're too fat, and we're too sickly, right? And if only we would just improve, then our maternal mortality would not be 3 to 4 times the rate. So the data shows that black mothers who are college educated fare worse than women of all other races who never finished high school. So we cannot educate our way out of it, right? We go to all these schools and we still die in childbirth. Obese women of all races do better than black women who are of normal weight. So me losing weight, I'm still not going to catch up. This is a mess. Black women who live in the wealthiest neighborhoods in New York City. So New York is high. So if you're living in the wealthiest neighborhood in New York, you are really living in a wealthy neighborhood. Do worse than their Hispanic and Asian mothers, than white, Hispanic, and Asian mothers in the poorest neighborhoods in New York City. Okay. And African American women who initiated prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. So think about all the interventions y'all make up. None of them matter, right? Y'all have been trying to kill us. I'm determined to say, stop it, okay? So stop telling me I gotta go to the doctor because it's gonna make my outcomes better. Stop telling me I gotta lose weight because I'm gonna make I need you to stop treating me poorly. That's what I need you to start with. Start there. So I want us to have some common language around racism, because I think when people hear the term racism, or me advocating for us to be actively anti-racist, you think I'm talking about tiki torches, right? So the mean people who are at Tuskegee, or the mean people in Charlottesville walking around being mean to people. No, it's a system. It has different layers, and we're going to walk through them, just some definitions to have common definitions. Which, these are from Kamar Jones, who is like my favorite person in the world. And the first one is institutionalized. So it's the structures, policies, practices, and norms resulting in differential access to the goods, services, and opportunities of societies by race. So the example that people in healthcare and public health understand is Medicare and Medicaid. Y'all know this story already? So Medicare and Medicaid was funded in 1965. You know where we were in 1965? Black folks didn't have access to a lot of things. So in order to get the Southern senators to agree to have a free health care benefit for poor and black people, they had to agree that they controlled it. So Medicare, which was perceived to be for whites because it's something that you got after having worked, and in their minds, all people who had worked were white people, then therefore the benefit for Medicaid, they wanted to control because they didn't want us to be forced to have to pay. This sounds familiar for today, right? Still having the same conversation. They didn't want to have to be forced to have to give health care to people that they didn't think just undeserved poor. So since the inception of Medicare and Medicaid, we've allowed for Southern states to not to have to invest in health care for poor people. Right? So that's an institutionalized racism. Personally mediated, that's the tiki torch. That's you call me a name. You know, I'm sure every person of color in this room has had a tiki torch moment, and you just kind of, either they're big ones, right, or they're small ones. Like I walk in as somebody who was a scrub tech when I was a physician here, came in here. I can remember going in the OR, and they would assume I was a scrub tech almost without fail. Or they would assume I was here to roll the patient in or out. So that's constant, personally mediated. So it doesn't have to be you just called me the bad word. You can just think that I'm the bad word. And then internalize it. This is the one, so Kamara said this out loud. She doesn't change it in her slides, but since she said it, I changed it in mine. So I saw her speak right after the election of the current president, and she was like, you know, this thing about internalized, we usually talk about it for black folks, right? So we've internalized these ideas about our hair and our skin and our culture, and we say these things negative about our own self. So it is the acceptance of negative messages. But you know, there's also an acceptance of entitlement by the non-stigmatized group, right? And so that's a whole new thing that we have not talked about. So it'll make you do something like vote to not have Medicaid when you need it in Kentucky, because you feel like your white skin is magically going to make you not need Medicaid. Turns out you still have an opioid crisis and you actually need it. It's not just something for black people. So this acceptance of a entitlement based upon race is just not real. And we're seeing higher rates of white death, you know, deaths of despair, because the realization that it's not paying off so well, this entitlement. It never really did, but it was a great narrative to have, I guess, or to keep us separated and fighting each other. Poor whites and blacks. So the reason that we have racial health inequities is because we have this narrative of individual versus collective accountability. And so, and I want to read it. Oh, I can't because it's at the bottom of the slide. So in Ibram's book, he talks about the reason that people use race for three things. Politicians use it to seek self-political interest. So we already had this idea of a racial hierarchy that was created. And so it's an opportunity for wealthy folks to use it to grow more wealth. So you can hear politicians immediately say a racist phrase that keeps people fighting each other, like Medicaid is only for certain populations, right? And so for self-interest. Capitalists use it to get more money. So rich folks love making poor people fight each other around racist ideas. And then folks like us, cultural people like me, we could use it for professional advancement. I get y'all pay me to come talk about race, right? So there are people who can use it for negative, for bad. They use it to talk about the importance of having a racial hierarchy, which is what we've had for hundreds of years. Now the reason I use this slide around the fact that 87% of the black experience in the United States has been under explicit racial oppression is not to say, oh, you know, slavery was so long ago, or oh, it was so bad, but to more think about, all the things you have to have in place to hold this for 87% of the time. So getting the right to vote is not going to fix that. Now, getting the ability to access even to desegregate schools is not going to fix that. Because guess what? People just resegregate. We've held this belief system and this for so long. It's in our textbooks. It's in our how we talk about health. It's how we talk about in our media. This belief that black people should be owned, are not fully human, and don't have the capacity to have full autonomy. And one of those, so you guys, I'm sure, all know about redlining. Yes? It's the redlining, yay! So we can go through this, but it's important because New Orleans, have you seen this map, the New Orleans redlining map? And so sometimes it's funny for me to think about how Lakeview and the suburbs, and then I live in this little blue area, and when I bought my house, my friends came and took pictures of it. Black people on Fontainebleau, they were like, Lord, we gotta put this on the bridge to do, right? So, because it was a blue area, and that's a new thing. So just, and also the irony of this map for me is both New York and New Orleans have a lot of red. And there's a lot of area that was really mixed, like a lot of people, a lot of black folks, and you stay like that. So we still have a chocolate city, majority black, all this stuff. And so think about the places that, but what you see on the outside, the suburbs, there's no red. There was not going, there was intentionally never going to be any red. So I am a fake community organizer. You know, so if there are any real community organizers in the room, it's just cut me a little slack. You know, I like this, but really, in order to understand racism, you have to understand power. If you don't understand power, you're gonna beat your head all the time trying to figure out why you can't get paid leave accomplished. That seems like an easy one. Who doesn't want paid leave? Okay, so in order to understand power, there are 3 levels. Well, first, power is the ability to achieve a purpose. So when you have collective impact, right? Sounds sexy, but who has the power in the room? If we don't address power, there will be no impact of the collective. Just remember that. All right, so whether it's good or bad depends on the purpose. So worldview. For the longest time in America, the worldview that was created by our cultural beliefs, our norms, our traditions, our histories, our faith traditions and practices was we are a survival of the fittest nation. That if you achieve and work hard, you can go out west and get you 160 acres, which is what white folks could get. We were just trying to get 15 acres, but 160 acres if you will work on this land and it's yours. Right, so that is a worldview that then led to an agenda. So this is a conscious and subconscious. So when you think about survival of the fittest, that agenda also says, I am going to make sure that the people who are the most fit have access to goods. The people who have worked hard and who deserve the merit, who did all the things they should do, get access. And the rest of you didn't put in the work to get here. And so then, from that agenda, you get policies and laws that are created. So the policies and laws would be Medicaid versus Medicare, right? So you don't deserve poor people because you didn't work hard. You're poor. Look at you. The policy and law that I can put together is that you won't get as much money for your health care. So then there's a separate worldview that says we're all in this together. So I would argue for about 8 years we had this other dominant worldview that said we're going to work on, we believe the least of these is also important. We're going to work on marriage equality. We're going to work on expanding Medicaid and make sure that all the states have Medicaid access up to 132% of poverty, that everybody, we're all in this together, and if the least of these fails, some of us fail. And so you went through worldview, agenda, and then it made different policies and laws. Okay. So the question for us as organizers is how do we get these 2 different worldviews to meet? If we have survival of the fittest and if we also have everybody, even the least of these is also important. And that's where we are as a country, trying to figure out which worldview will be the dominant worldview and who has the power controls what becomes the dominant narrative. And so my hope is that all you amazing anti-racists will be the dominant worldview from now going forward. But they're looking at some alignment. So usually some language around safety, security, both worldviews think of that. And so then how do you create that into an agenda and policies that believe that Louisiana should be safe? So when I would go to try to talk about Medicaid expansion at the state capitol, we need it for safety, right? If we are sick, if people are having outbreaks of flu and we don't have a universal access to insurance, then even the survival of the fittest folks will also get sick because we're not all safe. So just finding ways to align the worldviews is how you will get your political agendas through. Welcome to Tulane, y'all. So I did my residency, as was mentioned in my bio here. So I spent 4 years, I feel like I spent my entire adult life parking in the same parking, the heel lot, right? Med school, residency, working for the city, same parking lot. That's not a lot of progress. Anyway, so Dr. Cartwright, who was a professor here, created a disease. It was for runaway slaves. If you wanted to run away, you were deemed to be mentally ill. So he had power, and he could create policies. And so this disease is called drapetomania. We actually have T-shirts that say, disease called drapetomania, freedom, that we made at the African American Museum a few years ago. And so if you were black, if you raise your eyes to the head level with your master, that was a symptom. You just can't look me in the eye. This is in textbooks, medical textbooks. If you were sulky and dissatisfied, and if you wanted to live free, like a free Negro, all of those were symptoms of drapetomania. So think about all the ways that plays out now today when you think about the responses that people have to the police violence on black people and what they think that means about the black people versus what actually is happening in the life. Like, if you perceive any response to being treated poorly is something wrong with you, then you have to think about, I want you to immediately think of Dr. Cartwright. And if you see that your views align with his, you're probably on the wrong side of history, because at the time when he wrote this, he was on the right side of history. Turns out today, he looks kind of crazy, right? Y'all don't want to look crazy. All right. So some of the prevention and cures, this is medical prevention, was to punish until submission, whip the devil out of them, and put them in hard work in the sunshine to bleach the bad out of them. That'll cure their drapetomania. Yes, physicians, my people. So choice points. This is another part of my fake community organizing, but, or not fake, it's real. I just, I'm an OBGYN, so it feels a little awkward at times. So when we work with state health departments, city health departments, big legacy organizations, hospital systems, we get people are so gung-ho and excited about doing the work, and they listen and they come up with plans. They get to this moment and they do the exact thing they've always done. So if we say in our plan, you don't have people who work in your office who represent the community, who come from Brooklyn, right? You are here, right? We got so you have the power to hire people of color from Brooklyn. Yes. And then we get to where, guess what they do? Hire somebody who went to Tulane, who is from California, right? Okay, love y'all. Probably a lot of y'all in here. But the point is that's not doing what you said you wanted to do. It's a choice point where you revert back to your normal, what you would normally do. For equity, for having a racial equity lens, that's not going to get us there, right? So you know the right thing, you're going to have to make the hard choice. You're going to have to critically assess your own personal biases and look at the power dynamic and make different decisions, right? So that is for all of you when you're running your health departments in, Alameda County. I'm going to need you to hire some Alameda County folks. I'm going to need you to make sure that it is impossible to not find talent of color. It is impossible. Trust me, it is impossible. So if you don't find them, you were not looking, because we are everywhere. There's some amazing, smart folks all over the country. So implicit bias, y'all have had some implicit bias talks, yes, I'm sure. So the lovely Dr. Devine, who's actually ill, who created this term in 1989, Patricia Devine, she's a psychologist, she hates the term now. Shockingly, I know y'all are surprised by that. Because it's become, just like the social determinant, it's a word that's overused, that people don't understand, and they make all their other meanings. So she's trying to use unintended bias, because people, but anyway, so semantics. But it is implicit bias, an aspect of prejudice that is unconscious activation of notions of race, gender, ethnicity, age, or other stereotypes that influences our judgment and decision-making capacity. So bias is inherent. Have any of y'all done the test, the online implicit bias test? Yeah? Hey, I'm biased against old white dudes. Who would have thought? I know, it's like shocking that. And so it's an unconscious assumption based on perceptions about another that skew our understanding and unintentionally affect our actions and judgment. And it opens us up to prejudice and preconceptions based not on any reason or with the individual that you're actually dealing with. And so some of the things you can do, and these are the strategies I utilize with old white dudes, is I do stereotype replacement, right? I get on planes and immediately I sit down and I'm waiting for, don't you love our president? That's usually what I get. I'm like, you just want to start a car. I did not used to get on planes and say, don't you love our president? A couple of years ago, I never did that. I don't know why you feel like you do that to me, whatever. But I started, so I would brace myself, and then one time I did it, and the guy was like, hey, I'm from Canada. I said, see, I'm going to pretend like everybody's from Canada. So when they sit down, I'm going to replace my stereotypes in my head, and we'll just see how it goes. That way my heart rate doesn't go up, and we'll be fine. So we're individualizing instead of generalizing. Thinking about why would a person feel like they need to tell me about the president? What is the point of that? So walking in their shoes and their own insecurities or their own feelings around needing to, have a conversation around it and understanding, giving some empathy on reflecting on why that happens. And then lean into your bias. So this is the hard one for folks. We live in spaces where we don't see people that we're biased. So I don't interact a lot with old white dudes. I used to in hospitals, and then I would kind of run from that as well. In doctors' lounges, I go sit in the nurses' lounge or something. But so increasing opportunities to be able to lean into what you are biased or who you're biased against. So this one, has anybody seen this paper, The Effects of Whiteness? Yeah, this is one of my faves. We have thousands of papers on the effects of blackness. Yeah, we've been doing that for 400 years. I could tell you, well, this happens to black people, but we have like nothing on the effects of whiteness. And I always talk about the third author, Dr. David Williams at Harvard, because in my mind we're friends, we hang out. My husband came home one day and put his card in the bathroom counter. I was like, you know Dr. Williams? He's my friend. Anyway, so he does a lot of work around race and health, and they wrote this article about the effects of whiteness on health. This is a startling idea for folks because they don't think about it. But just like we created the culture of blackness, being white is a thing. It created a culture. It has some impacts. So the positive impacts of whiteness are positive illusions or belief of American meritocracy. This is quoting from the paper, that promote a self-enhancement. It feels really good to believe America's great all the time, right? I remember Cornel West had a quote after the September 11th thing. Did y'all remember this? Is kind of he said, how does it feel to be an N-word, right? Because to be hated, and you've done nothing, right? People just hate you. That's what being black in America is like. I just got here. You mad? So the belief that America is always great, it must feel really, really good. I mean, I don't know. But psychological benefits from economic and social policies that favor the dominant culture. So thinking about the spaces where we have policies that say we're going to give money towards two-parent married households, because that's the dominant culture narrative. And it's never been the dominant culture narrative in black America. Because we were legally not allowed to get married. Let's start with that. But we have created so much policy and structure to incentivize that because it is the dominant culture. And so 57 to 62% of white Americans believe that white life has changed for the worse since the 1950s. I would argue you wouldn't get black folks to agree with that one. 50 to 60 believe that discrimination against whites is as big of a problem as discrimination against blacks in the United States. And so this is where this kind of redemptive narrative, right? And I do this talk, one time I did it with some any Native Americans in the room? I did this with some Native Americans, and they really understood this really well because we never believe, black folks always believe we'll have a second chance. Always. Like, you can knock me out, I'm coming back, right? Like, this is what this is. So there's the belief that if something happens, it's the end of the world. If the crash happens, so that's why you get white males are 28 times more likely to commit suicide than black women, right? Because if I'm always supposed to be high or up and nothing never is supposed to be bad, that is not realistic. Stuff happens. So when stuff really happens, the coping mechanisms are not there. So we have to be able to deal with this is not a truth. This is not healthy for anyone to believe that you can't ever be down. This is not healthy for any community. It's not healthy for any group. And it causes inequities and disparities. So this idea of race and racism doesn't just impact black people. The false narrative around you always having to have and be wealthy and causes West Virginia to be West Virginia, right? Causes Appalachia to be disconnected. Like you are not, you see some of the same narratives in those spaces because they have they're not allowed to have a coping mechanism. They're not allowed to have a redemptive narrative, and that's not fair. It's not fair. So he, of course, they're fancy Harvard people, so they have a whole framework. And what they say in this framework is, at the end, this is just a framework. So what they want is more people like you actively anti-racist people, to write more papers with this framework, and you can add to it. He's like that. He's super nice. Like, this is just the beginning of a conversation that we don't have in America. What is the impact of whiteness on our health? And how do we then ensure that we address that? And so I suggest that some of you write a paper about it. It'd be pretty awesome to get published. Because if you look at the U.S. infant mortality rate, I usually say this, the South and the Rust Belt always do poorly, right? And those are places where we underinvest in education, we underinvest in transportation. Like, why don't we have a light rail? Why can't you go from Baton Rouge to New Orleans? It's silly. Like, all these are choices around disinvestment. And if you look at the black infant mortality rate, it's about the same, the South and the Rust Belt. But the white infant mortality rate is the same places, because it's just better than ours. So when you underinvest, because race, thank you, is not genetic, when you underinvest in education, when you underinvest in transportation, when you underinvest in any of the social structures you need, you also hurt white people. They just aren't hurt as poorly as black people who had slavery and other things before, but this is important to understand. If I were white, I would move to, I don't know, Connecticut maybe? California, somewhere, where I could actually get some benefit of my whiteness, because it's not working out in Louisiana, right? Like, I just did a talk in Texas about maternal mortality. So in the film, we talk about how in New York City, black women die in childbirth at 12 times the rate of white women. And so this is like a huge statistic, and mostly it's because the black rate is bad, and the white rate, though, is amazingly good. Like, white women rarely die in childbirth. So in Texas, both numbers are bad. I was like, so the reason y'all don't have the disparity is not because you're doing so great, it's just because you don't have Medicaid expansion, you don't have access to reproductive rights, you don't have paid, you have all the bad things that make everybody die, we just die more. So if we worked on this together, we could all live. So that's why we need to not skip equity. We need to stop saying, let's pick the low-hanging fruit and the easy thing and make some billboards, because that's the status quo. And it undervalues communities with the highest risk of poor outcomes. It's inefficient, and it discourages community partnerships, and it perpetuates racial health inequalities, and it fails to create opportunities for innovation. All these new ideas that we could be doing. Well, think about, if the number one cause of infant mortality is prematurity, how many programs do we have around prematurity? Who's working on that? Crickets. It's not so hard, so much stress. Okay, but we're gonna have to do it. I have the great benefit of being a part of the Kellogg Foundations, and have been a part of the Truth, Racial Healing, and Transformation work. And they're doing it here. Anybody else here in that space? Yeah, I figured. Here in Baton Rouge. And countries that had a history and a legacy of slavery, some of them have done this work, and we're trying to do this here in the United States. And the first part is having some truth. Honoring the fact that we did make laws to create inequities, that we did make redlining, that we did have segregation, that we do still do things like recreate public housing and knock out and decimate communities and not give them a place to live, and then expect them to go I don't know where. So it addresses the historic effects and contemporary effects of racism, and it seeks to unearth and jettison a belief in a hierarchy of human value. So at its core, being anti-racist means you don't believe that any race is better than the other. That's all I need you to do. Just every time you feel yourself thinking, or subconsciously thinking, oh, this person is better or worse than me based upon skin color, realize that that's wrong, right? That there is no hierarchy of value based upon race, and that you're actively going to look at all the places within your individual life, in your policy life, and your work life where that plays out, and work to stop it, because it hurts all of us when we have this belief of a hierarchy based upon race. So the lessons learned for us as an organization, while using this making racial equity real, is it's a high-level social goal. health departments and hospitals really want to invest in equity, and they're more prepared and willing to center it right now. This is, one of the benefits of our current administration. Everybody's like, okay, how do we fix this? This is not working out for folks. But the clinicians and healthcare workforce have to be educated. When I give this talk to doctors, we still have a lot that believe that race is genetic. I went to medical school here in 1997, and my embryology teacher said there are 3 races: Mongoloid, Caucasoid, Negroid. That's 1997. It's not that long ago. So there are people who practice medicine in the city who believe that, right? So we have to start really actively debunking this belief in races that are genetic and therefore entrenched in inequities. The healthcare system alone is not equipped to overcome health inequities because it was created on an institutionally biased, racially biased American society. So it's flawed from the beginning. Just like we're stamped from the beginning, our system is flawed from the beginning. So we have to unpack that. We have to have multi-sectoral collaboration. We have to acknowledge intergenerational and family aspects of health, and realize that families are their own greatest advocates, not us. Bringing the voices of the actual people who are impacted to everything that you do, to have their wants and their needs embedded in that, and to amplify those voices. Use your power to make room for them, to amplify their voices. Oh Lord, I have a whole bunch more slides, huh? I'm gonna skip through these. This is just a talk that I give around intendedness, which is like my second, after SIDS, intention is my second least favorite thing. And so the history of oppression and contraception in the United States, this goes through, the fact that Black women had their own contraception, and that talking about the first family planning clinic. So under President Nixon, he created the Office of Economic Opportunity. Sounds familiar like today, right? And his goal, his treatment for economic opportunity for Black and brown people was family planning. And so I would argue that instead of worrying about our reproduction in 1970, if he had given us free college, we might actually have not had poverty. But we have been trying to work on women and Black folks' reproduction to improve the outcomes for poverty for about 50 years now. And the word unintended came from a survey that was done in 1965 and 1970. And at the time when it was done, there was no difference in married and non-married people. White women said that they didn't intend to be pregnant. But there was a poverty, educational level, and race correlation with wantedness. So this is today. 38 per thousand white women have intention versus 92 per thousand. If you look at the reasons these are women who were not using contraception and who had an unintended birth. If you look at the whys, for white women, it's usually, for Black women, it's, I didn't think I can get pregnant. So some of that is we don't do a really good job with sex ed, and we don't trust the healthcare system. And I don't like, and the other reason that Black women said that they weren't on birth control is because they had side effects from the medicine. They didn't like the side effects. For white women, the main reason was, it didn't matter if I got pregnant or not. So what that says is, if I have enough resource and capacity, this whole intention is a moot point. If I'm healthy and I have a job, I can just get pregnant. So instead of working on keeping people from wanting to, how about working on everybody having the space and capacity for them to be able to? That's a very different frame. So this is from the CDC. The gentleman who writes this report every year is the same guy. He copies and pastes and he just changes the numbers. And then he comes up with what are the reasons why. So when I was in residency here, they came up with a bunch of different contraceptions because the goal was, the reason why Black women didn't take birth controls was we didn't like side effects. So they made up things you can put in your arm. They made up different types of IUDs. We have different types of ring, the NuvaRing, all patches. We had about 20 new different ways of getting birth control to work on this one thing, which was the problem was Black women just didn't like side effects, according to their data. Turns out after all those years from 2008, Black people's intention rate didn't change. And so they don't understand. We did all this stuff to give y'all new ways to do it. And his reason is because there's an increase in proportion of births that were non-marital, so married people have intended pregnancies, and that there were more changes in race where people from Hispanic and Black folks were here. So it's really the problem is we're not married, it's more Black and Hispanic people. That's why these problems all exist. Once again, problematizing the folks. and that married non-Hispanic white women had a great increase in improvement in their intention rates. So they got together a committee at CDC to look at the word intention back in 2003 and saw that it was a problematic, and it's time to go back and relook at it again. If you look at the states where they have unintention, it's the same as the states that we have for infant mortality, it's the same as the states that you have for poverty. If you are poor, the likelihood that you're going to say you intended to be pregnant is pretty slim. So perhaps instead of us concentrating on people's intentions, we should work on their economic opportunities. So skyboxification of American life. The rich and poor no longer rub elbows, and the bleachers are stadiums. In that context, the skybox of healthcare should not be surprising. While it would be hard to argue that everyone is entitled to personal chefs and preparing their hospital meals or roses on their end tables, it is unsettling when those hospitals with pedestrian food and bare tables can't afford to have an interventional radiologist on hand to treat women of uncontrolled hemorrhage, a leading cause of maternal death. So we have segregated healthcare in New Orleans, we have segregated healthcare in New York City, and that causes maternal mortalities and infant mortalities. Oh Lord, I have way too many slides. This is about the difference between how we frame the opioid epidemic and the crack epidemic when it comes to black and white women. For white women, the narrative is that they're America's sisters and daughters. It's an epidemic of despair. It's considered a disease. Now we have fetal abstinence syndrome. When I was a resident, we just had crack babies and crackheads, and there was no syndrome. There was no fancy name. There's no conclusions made about prenatal opioid use among some steering committees here, and the doctors want to test all women because they're too nervous to ask white women if they're on drugs. And they're like, we should just screen everybody. You can't just screen everybody. Our current administration wants to give $45 billion to help and to make sure that we can have help for the opioid narrative. And then southern states that led in criminalizing black women when it came to marijuana and cocaine and crack abuse have all these, they have a softening of their policies. Now when it comes to cocaine addicted mothers, the narrative is illicit drug uses among white women is just as prevalent, but we don't talk about that. It connotated careless black motherhood in inner cities, the black baby narrative, that we were biologically inferior, that we were making super predators and killers, and it led to mass incarceration of black mothers through random drug testing and leveraged child removal and incarceration. Two very different narratives around substance abuse and outcomes. The woman who created the term crack baby, and not created the term, the woman who said that children who were born crack addicted were going to have poor outcomes forever, followed up and turns out they did not. And so, just like the woman who created implicit bias doesn't like the term, she's trying to pull back that data as well. And so you have to understand community context when you future leaders of public health departments are going out to do your work, and understand this dichotomy between the fetal abstinence syndrome and the crack baby, and including making sure that you have community voice in all the policies that you create. And this is about segregated hospitals. We talk about the black serving and white serving hospitals in New York City. This is the redlining in New York. This is the same map of where they had high maternal mortality. It's also where they had redlining. In the United States, 3 out of 4 black mothers deliver in only 25% of the hospitals. So public policy should not sort the haves and the have-nots, because it makes for inequality. Housing segregation dictates access to low-income families to low-performing hospitals. And we need to conduct a better analysis on community voice, accept Medicaid without exception. I think that's it. So addressing root causes. So despite available evidence, opinion leaders, local change agents, and policymakers give little attention to inequities in their root causes, and they typically focus on remedial options, such as psychosocial stress and unhealthy behavior. What you are going to do going forward as actively anti-racist is focus on the rest. And you're going to not be a segregationist or assimilationist, but you're going to be actively anti-racist. And I think that is it. Yay! So you have one more song? Okay, so we can do some,
A couple
yeah.
of questions.
Yeah. Does anybody have any
Any
questions?
questions? There we go.
Let's go. What you got?
Well, thank you.
Thank you.
And I have a question. The statistic around when Black women have early prenatal care and their outcomes with other women, it seemed like it was mostly clinical. Do you see anything changing when you have like NFP or interventions or policies for any of that?
Yeah, so that would be an excellent follow-up to that study, right? Like, what are the social structures you would need to ensure that Black women still have good outcomes? Would it be a doula? You know, would it be a midwifery model of care? You know, so like, how do we then? Because we created a system. I would say we created public education and healthcare for a certain demographic, right? And so when you go outside of that demographic, we just don't have a lot of structure for that. Instead of what you would do in racial justice or racial equity lens, you would create the system based on the most needy, right, on the most marginalized, and then you could peel off what you don't need versus having a system that says, you know, this is the standard, and then trying to add on stuff. Yeah. Any other questions?
What do you see as living in New Orleans now, and you know this reading?
I know.
You've been here
A long time.
When we look at many of the disparities that we see, you talked about it inside the presentation. When we look at many of the disparities, one of the factors that I think we don't talk enough about, is the fact that we have individuals making decisions that don't look like people that are affected.
Yeah.
And so when you were here, how did you keep that at top of mind?
Yeah.
How did you navigate that? Because a lot of what I'm seeing in my present population of color,
Yep.
we have people who don't look like the disparities, and they're making the decisions.
Yeah.
How did you navigate that? How did you continue to navigate?
Yes, and you know, the good news, well, the sad news is not just New Orleans, right? So the beauty of the work that I do now, I get to see that it's every single place we go. When I think about the place that is the most diverse, which is California, they have active policy and strategy to be inclusive. So they like hold it accountable. If you don't have people who look like the impacted, you don't get the funding. So that is a thing. The hard part for New Orleans is we've had this kind of plantation, I'm the overseer narrative in this community for a very long time. So that's why the statues was not just a symbolic moment. It's a real moment of we no longer will allow for just a few, the shadow government, to control all of these things. And it's complicated to navigate. One of my favorite experiences, because I was young and new in the public health, I was all excited. So that Katrina hits, and I'm over the healthcare redesign and ensuring that we get more young people to stay in New Orleans for healthcare. So they give me the task of coordinating the medical school deans from Ochsner, Tulane, and LSU. So here I am, early 30s, and the deans have to talk to me because I'm talking to the U.S. Secretary of Health about what the strategy is for healthcare for this people. And I just remember saying to them, well, 80% of people stay where they train. So have you looked at the needs of the community so that you can train providers at Tulane and LSU based upon what they need? So if we need more neurologists, why don't you train more neurologists? And the Power said, we train based upon what faculty we have, right? And so that choice point is real because they're committed to ensuring that their staff and their friends have jobs, and not necessarily that the community has access. And so our job is to hold them accountable, and they just keep calling it out like you do, keep calling it out. Yes.
So we have to wrap it up. I'm so sorry.
Yeah.
If you signed in or gave me your email address, we will email out the slides, right?
Yes.
And the recording.
Yes.
Thank you so much, everybody, for being here. Thank you, Dr. Crear Perry.
Thank you.